Now we have with us Dr. Deependra for his talk on apparatal membrane.
Yeah, thank you, Professor Manisha and AIOS committee for allowing us this session, invited one. And I'll be speaking on another double trouble, epiretinal membrane and cataract, and how do we take care of this in our practices. First of all, I went back and tried to find out that is this a common thing, that do you see ERMs when in patients who have cataracts. So a lot of people have actually already started doing pre-operative OCTs for their cataracts. It initially started with premium IOLs because we all were promising a lot. So everybody wanted to have a good healthy macula before advocating a premium IOL. But then when everybody started doing it, they realized that there were a lot of macular problems which were missed in patients who were scheduled for cataract surgery. And this is just a couple of studies I am showing, but there are a lot many studies available in literature. This one is from Poland, which found that when a good ophthalmologist has certified a normal fundus, they have said that this fundus is normal, and then on those patients when OCT was done, almost 12% had macular problems, with ERM one of the most common macular pathology. Similar study in Brazil have found around 7% incidence of macular issues in patients where macula looks normal on fundus examination. So that means that in our population of cataract surgery patients who are scheduled for cataract surgery, ERM and cataract is going to be a very frequent finding. In fact, when we discuss with my VR colleagues, we are often discussing that macular surgery is slowly becoming the most frequent surgery done by us. And I see Dr. Ashish nodding. So because I think we are detecting more, we are operating more and more cases. And this is a case almost 2 decades back. We operated, you see, idiopathic ERM improving nicely after surgery. All of you have seen these cases. And now we are operating other ERMs also associated with lamellar holes and LHEPs. So in general, I think what I would recommend everyone, because you will be doing OCTs for your cataract patients. So there are a lot of new terminologies which have been introduced based on OCT, and OCT has become a most important tool for detecting ERMs and categorizing ERMs, which one to operate and prognosticate how will they behave after surgery. So it would be a good idea to just get familiar with all those new terminologies and classification. I am not going to cover them, but just to share that there is a very good classification based on EIFL, which is known as ectopic inner foveal layer. This has come from Govito's group, and this is very useful, prognostically useful classification. I think you can just ask your retina colleagues to update you on this. Then there is a entity called ERM with lamellar macular hole, which Spade and all have very nicely described it. They behave differently from the top category of ERMs. Then there is a condition called LHEP, lamellar hole associated epiretinal proliferation, which are not good surgical candidates. And then one also has to differentiate whether it is an ERM or vitreomacular traction. So this is slowly going to become a basic information related to ERM, which all our even comprehensive colleagues should try to get familiar with. But the big question is, does ERM surgery is worth it? Many times, we have discussion with our patients and colleagues, and they often raise this question that you remove so many ERMs, is it worth it? So there are n number of studies available in literature which have shown that it's not only just metamorphopsia or near vision which improves, even quality of life and other functions also, they improve significantly after removing these ERMs. And there are n number of studies which have shown excellent visual gains, and I think all my VR colleagues will agree that this is one of the most gratifying and least risky surgeries out of all our vitreous surgeries. So, but again, we don't jump to surgery just because it is safe and it is visually gratifying. So whenever we encounter a patient with cataract and ERM both, we have 3 options. One is we just observe, don't do anything, and this actually applies to situation when both conditions are not qualifying for surgery. And if both conditions are qualifying for surgery, then combined surgery has huge advantage, and I'll come to that in the later part of this presentation. But then there are other considerations if you are planning for a sequential surgery. You to do cataract and then evaluate and then plan a VR surgery later on, that there are I think some issues related to that approach. One is, although it doesn't worsen frequently, but in vascular cases at least, there are chances that ERM or VMT might worsen after cataract surgery. Now this becomes a huge setback for a patient who has undergone cataract surgery and he has not achieved an optimal visual outcome. And of course there are financial and logistic disadvantages of doing a sequential surgery, which we all understand. So how do we decide that which are the good candidates for surgeries and which are poor candidates? So patients who are having, in general, having idiopathic ERMs, I think, which are not associated with any other macular pathology, especially if they are symptomatic, and metamorphopsia is rated highest. I think if you actually, you have to ask a leading question from your patients, that do you see distorted? Ask most of the time we spend with these patients is asking about their reading habits, how they are reading, how much they are reading, and are they experiencing any distortion or broken letters, or is it just blurred near vision? And another thing, most of these ERM patients have a PVD, which pre-existing PVD, and they are also troubled by a floater, which can be sometimes really disturbing for these patients. So again, our threshold for surgery in these patients who are symptomatic would be much lower than asymptomatic patients. And of course, if you are following EIFL based classification, stage 2 and stage 3 are the ideal stages, I think, for surgery. And the poor candidates are if you have an associated degenerative disease like macular telangiectasia or neovascular AMD in ischemic retina, or if it is associated with uveitis, pars planitis. All these cases, I think we are not in hurry to operate, and we can always plan a sequential surgery, or we can just observe also. Similarly, advanced stage ERMs with total disorganization of inner retinal layers, what is called as stage 4 ERMs, they are also not good candidates for surgery. And this is just an example of ERM in a patient with uveitis and cataract. You can see this striation and significant ERM. I think this is also a very old case. And we were actually thinking of doing surgery for him, and he came back smiling, and you see vision improves. And I think there was a spontaneous PVD, and ERM just opens up. So, but when we are counseling these patients, our main, because see, cataract, diagnosing a visually significant cataract is not a big deal for everybody. All of us we start doing it in our post-graduation itself. The key question is how much disturbance ERM is creating. So we have to spend more time in that, evaluating history-wise and clinically. And if you can have M charts, I think they are even better. But you can use your conventional Amsler grid to chart their metamorphopsia. But also don't go just by OCT picture. We see a lot of patients with significant ERMs, but they are reading 6.6 and 6 and no metamorphopsia. So we can't just go by OCT picture. Another patient, you see significant ERM, you can see significant ERM, but it is just temporal to fovea. OCT picture also dramatic, again reads 6.6 and 6 asymptomatic. So we will not do jump for surgery in these patients. But in general, our effort is to plan a combined surgery whenever indicated. And sometimes you will encounter a patient who has a very early cataract and early ERM. We don't mind following this patient serially and tell them we are not hurried to do any surgery for you. And we will, whenever we'll try to do it together, but let both pathologies earn surgery over due course. And if we see ERM with loss of outer retinal layers or any other signs of poor prognosis, anyway, we'll just plan only cataract surgery. We'll leave the ERM alone. And many of these patients have just cellophaning, and which is long standing. If you look into their old records, it has been mentioned 5 years back, 6 years back. They are non-progressive kind of ERMs. They can also be left alone, and you can just go ahead with the cataract surgery. And in general, if you have a significant cataract and a ERM, in our setup now, we'll rarely do this, that we'll do only ERM surgery and plan cataract later on, because we know a progression of cataract would be accelerated once we do vitrectomy. So that option is very less commonly used. And I think I'll just, I think that many times these patients have one eye which has been operated with a premium IUL. and with a femto or conventional good surgery. Now, once they are approaching us for fellow eye, you end up finding a ERM. So now, do you change your plan for cataract? Do you change your lens, or do you change your technology? We don't do it unless we feel that visual potential is limited, because many of them would improve to 6/6 and 6. So, and they don't have a progressive retinal pathology like we were discussing for DME or AMD. There is a strong case of avoiding a multifocal lens, because we know that these pathologies are there and they are going to progress. But ERM is something which I think once you remove it, many of them will be stable and they achieve good outcomes. So I think we often combine our conventional premium IOL surgeries with ERMs, and you can see you can just remove the ERM and ILM. This is just after removing the ERM. So message I wanted to give was that you need not change your plan for IOL in cases with ERM unless you see some reason for poor visual recovery, because many of them will achieve very good outcome. This is unlike other macular pathologies. And again, I think I'll just skip the surgery part. This was again a very significant ERM, and we did a combined surgery. And even with this amount of thick ERM, she recovered reasonably good vision, and you see stage 4 ERM also improving to 6/12. But this patient, we didn't go for a multifocal lens, we went for a monofocal lens. So what are the advantages of combined surgery? I think in these cases is, one is logistic and financial advantage. You can always reduce the cost when you are clubbing the surgeries, and you are actually combining two visually gratifying surgeries, so it amplifies the visual gains. And we have done our own analysis presented at IRSI quite a few years back, that there is no impact on refractive outcome when you do a combined surgery for macular pathologies, whether it is ERM or macular hole. Earlier there was a concern that if you are using optical biometry, ERM might induce some errors in measurement of axial length, but this was not the case, and which a lot of other colleagues all over the world have also published. So that concern that your biometry will fail you in patients with ERM doesn't hold true. And this is quite minimally invasive. The another advantage what you see when you are doing combined surgery is you get a very crystal clear posterior capsule, and so the view is very good. So technically also I think it's a good option to combine these surgeries rather than letting PCO. If you plan it after 3-4 months, you'll have some PCO and other issues coming up, and many times you can find additional posterior segment pathologies. You can address them when you are doing a combined surgery. So I think with this, I'll like to conclude. Number one thing is, let's not miss ERMs when we are doing cataract surgeries. Incorporate good slit lamp biomicroscopy, and if possible OCTs for all your cataracts, so that you don't miss ERMs preoperatively, and get yourself familiarized with the biomarkers, which will help us decide good surgical candidates, and that helps in counseling also. And of course, goes without saying, don't get mesmerized by macula. Always look at the periphery. There can be additional pathologies. Many of them are secondary to pathologies in periphery, whether it is tears or vasculitis or other reasons. And of course, don't hold yourself back. If you see good visual potential, I think offer them a premium IOL and good surgeries, just like your routine patients. And of course, if both pathologies present very early, follow them serially, and I think give them an Amsler grid and tell them that you have an ERM which we might remove along with cataract. Yeah, so I'll conclude here. Thank you very much.
Thank you, Dr. Deependra. A very nice and a very comprehensive talk as always. But when I listen to your talk, I think we need to have a debate as to whether we should go in for a combined or a first cataract, and probably I am more in favor of going for cataract first, and then after 10-15 days the ERM. So since we do not have that much time, we'll have a debate sometime, and I'll do on the other
definitely.
side.
Yes.
But
Sir, even if you put these and you put gas,
I can see. I can just add one line. When we are disclosing the session, in this session we were focused on cataract and macular pathologies where we can do something. So there is always an option to do this sequentially. But one good interest what we have in when we are managing these patients is to see the visual potential. That is why, see, besides that, the fact that there is a possibility that macular edema might worsen after cataract surgery, but more than that, you want to judge the best visual potential of these patients. That's why you operate cataract also when they are dry, even for AMD, so that when they recover and come back to you at 2 weeks post-op, you know how much visual potential they have. Your future strategy, especially for progressive diseases like neovascular AMD and DME, will depend on how much visual gain they have. And it's a definite setback for patients when you do a good cataract surgery and they have reading issues and
just one last question, Dr. Deependra. What is, do you check for metamorphopsia or the visual acuity before deciding for going for ERM removal?
I think all three.
If visual acuity is, let's say, 6, 9.
Metamorphopsia, see, sometimes that's a very good question that we have only 3 tools right now, Amsler grade or metamorphopsia, near vision and OCT. So all 3 are pointing that ERM is significant and it is influencing the near vision. Then only you plan your surgery. That's how we do it.
Dr.
What is
Keshuk,
your like Dr. Ashish said, like you say after 15 days you do the ERM surgery. What is your cutoff point for the visual acuity? The question you were asking.
Usually I don't operate when it is 6/9 or 6/6. I don't operate.
Post-operative.
6/9 or 6. I mean, if it is 6/12, 6/18, then only I operate.
Thank you, sir.
We are running short of time already, but if you have important question, you can ask shortly.
Patient, nuclear sclerosis, N3, N3 to N4. No PSC, nothing. Improving to, let's say, 6/12 partial or maybe 6/18 on 6/12 partial. N6, 6/12 partial distance, N6 with epiretinal membrane. What would you do?
I think first do the cataract surgery and then assess the situation after 2 weeks, then you can plan it out. I think.
The important thing for the take-home message is that near vision,
Yes.
if it is improving to N6 or N6 partially with N9, indicates that the macula may not be so badly off. Cataract is the primary
Absolutely.
Culprit, yeah.